Back to another Facebook Live broadcast on the Neuro Collaborative. My name is Sarah King. If we haven't met yet, I am the founder of Invigorate Physical Therapy and Wellness here in Austin, Texas, and also one of the co-founders of the Neuro Collaborative. So today I'm really excited to talk with you guys about the topic of blood pressure, orthostatic hypotension, autonomic dysfunction, mainly because I went to the International Movement Disorder and Parkinson Congress in Vancouver, Canada a few weeks ago. It was beautiful and I learned a lot. The workshops I attended were mostly based off of the Parkinson's diagnosis. I know that not everyone out there only treats Parkinson's like I do, so I'm trying to keep this lecture generalizable to our kind of elderly populations, to our neurological populations, and of course we're going to talk about Parkinson's here a little bit. But if you guys have questions as we go along, please put them in the comment section below. I'm going to try and keep this as clinically relevant as possible, so we'll talk through a little bit of signs and symptoms of orthostatic hypotension versus autonomic dysfunction and some strategies that you can use in the clinic to help your clients manage their blood pressure better in a way that's safe and effective. So if you are new to the Neuro Collaborative, before we get started here, I just want to invite you to check out our website, iloveneuro.com, join our newsletter. We send out emails about different topics and videos and educational material all the time. So make sure that you're on that. And we are trying to get everyone to join our private free Facebook group called the Neuro Collaborative Professionals. There's a link either above or below this video depending on when you're watching. But if you just search groups for Neuro Collaborative Professionals, you'll find us, hit request to join, and we'll get you right in. Because the things that we can't talk about in depth on our Facebook Lives, we can dive into and really have some case studies and some real life examples inside our group. So make sure that you join that, and we can't wait to see you in there. So before I dive into some strategies, something that I think we talk about a lot as first-line providers, we have our doctorate in physical therapy, most of us now, and we are first-line providers, which means that we need to be really screening our patients effectively, and that includes vital signs. So especially in the Parkinson's population that I work with a lot, but really just our populations in general, neurological populations, we need to be looking at vital signs, mainly heart rate and blood pressure is what we're going to talk about today. So at every evaluation, I make sure to do blood pressure for all of my clients in supine, in sitting, and then in standing to track for orthostatic hypotension. I also, of course, take note of their medications, whether they're on antihypertensives or not, and just listen to their symptom history, which we'll talk about here in a second. But I want to encourage you guys, if you're not regularly taking blood pressure vital signs, those things can be a really great indicator of what's going on at a deeper level with our clients. So a definition of orthostatic hypotension, most of you know, but just as a refresher for us who've been out of PT school a little while, orthostatic hypotension is a fall of about 20 millimeters of mercury blood pressure of the systolic, or a drop in diastolic blood pressure by about 10 millimeters of mercury. So if either of those happen within 3 minutes of standing, that's diagnosable as orthostatic hypotension, and we need to be monitoring signs and symptoms that happen when our patients are hypotensive. And the reason why it's so important, some of us have orthostatic hypotension every once in a while. We stood up too fast. There's a lot of factors that go into our blood pressure regulating itself, which we'll talk about in a second. But having one bout of orthostatic hypotension versus having a consistent deficit in our regulating of our blood pressure over time can be a key indicator of if our autonomic system is functioning properly. So some causes of just a one-off orthostatic hypotensive episode would be, you're dehydrated, so your volume, your intravascular volume is depleted. Maybe you have some blood pooling in your legs from sitting too long or possibly from varicose veins. Severe anemia can cause orthostatic hypotension. And of course, if you're on an antihypertensive medication, like a blood pressure medication. That's what its job is to bring you down as far as blood pressure is concerned. And then also physical deconditioning, when you don't have that tone in your legs and your lower body to be pushing that volume back up to your heart and your head and all your other organs, then you can become hypotensive. So other factors that affect orthostatic hypotension could be food and alcohol ingestion, physical exertion, obviously something we're doing with our clients all the time, temperature, and different drugs and medications. So there's a difference between orthostatic hypotension, that's a one-off, maybe acute deal, and something called neurogenic orthostatic hypotension, or NOH. And that starts to indicate that our autonomic system is not functioning properly. So the definition is neurogenic orthostatic hypotensive happens because of reduced norepinephrine release from post-ganglionic sympathetic nerves that leads to defective vasoconstriction, so we're not constricting our vessels, when in the upright posture. So it's more of a systematic issue and instead of a kind of an acute issue. And that can give you an indicator that your autonomic system is starting to become dysfunctional, if not starting to fail, which is an emergency, all hands on deck situation when you have autonomic failure. We're not going to talk about autonomic failure today because we just don't have time for that specific topic. But if you have questions about that, put it in the Facebook group. We can definitely speak to that. But this neurogenic orthostatic hypotension happens a lot with neurodegenerative disorders that are caused by abnormal synucleopathies. So something like Parkinson's, Lewy body dementia, multiple system atrophy, those things are more likely to be, those diseases are more likely to affect your autonomic nervous system. So we need to be aware when we're working with these different populations because we need to be monitoring not just their blood pressure, but are they having falls? Are they having fainting spells? Are they having, do they have funny turns maybe when they get up and move, when they change position from sitting to standing, that type of thing. If we think that they're just off balance and we're not tracking their blood pressure, we could be missing a lot of kind of pieces of the puzzle as far as their treatment plan is concerned. So to kind of help you disseminate just an acute episode of orthostatic hypotension versus maybe a more chronic autonomic dysfunction, in our lecture in Canada, he talks about the 4 F's of autonomic causes of dizziness and syncope, which are funny turns, near fainting, or falls. So that can be start to be an indicator. You have to look at the big picture, but that's one piece of the puzzle that you may be having some autonomic dysfunction going on. And what happens with autonomic dysfunction is that your blood pressure drops, but your heart rate stays the same. It doesn't regulate itself to help everything equal out and start, pumping blood back to where it should be. So that's a failure of your autonomic system to restore your equilibrium. Some other evidence or symptoms that your client may have autonomic dysfunction include excessive or decreased sweating. So if you think of all the things that your autonomic system does in the background that you don't think about, sweating, they could either have excessive or decreased sweating, too little or no salivation at all, some type of gut dysfunction, so decreased motility or constipation, diarrhea, indigestion, nausea. Some urinary symptoms might include lots of urine at night, lots of frequency, urgency, and then the reproductive system is the way that it evidences itself is erectile dysfunction. So I don't know about you, but I listen to those symptoms and I think every single one of my Parkinson's clients have a lot of those symptoms, but I am not monitoring really closely everything together if I'm not really cued into what autonomic dysfunction looks like. So we could just say, oh, it's old age, or it's, we're just working with a population that's going to have a lot of dysfunction. We just need to be aware, calculating their vital signs, listening to their symptoms so that we can help them manage their blood pressure better if they need. So take your vital signs. If you joined late, take your vital signs of your patients at eval, in different positions, and every time you see them. So the thing that was really interesting about the lecture that I attended is he talked about the danger of chronic severe hypotension, so low blood pressure. And really the danger here is, and it makes sense, I just never really considered it a lot, was the fact that if your blood isn't going to the areas that it needs to go to, your tissues are what's called hypoperfused, so they're not getting as much blood as they need. And if your blood is pooling in your legs, for example, it's not getting to your brain, it's not getting to your heart, to your lungs, to your kidneys, to just your muscles in general. And so he gave us some examples of what it would look like for these different organs to be hypoperfused, or to not get enough blood pressure, not enough blood in those organs. And over time, when that's chronic, you can see why that would be damaging. Your organs aren't getting enough blood. But here are some 3 examples of tissue hypoperfusion. So we have brain hypoperfusion or cerebral hypoperfusion. Symptoms that your brain isn't getting enough blood due to low blood pressure is dizziness, visual disturbances, obviously loss of consciousness, and cognitive deficits. Again, sounding very familiar with our population. Muscle hypoperfusion. You can have what's called a coat hanger ache, which is, if you think about where your coat hanger is on, it's up here in your traps. That's where your coat hanger goes in your shirt. And so if these muscles here, they're subject to not getting enough blood. If they're not getting enough blood, you can have this coat hanger ache. So if one of your patients stands up and they say, oh, I feel a little bit dizzy and my neck is really aching, that can be an indicator that they're not getting enough blood up to their neck and up to their head. Another symptom or another kind of hypoperfusion that can persist is called renal hypoperfusion. So if your kidneys aren't getting enough blood, then you may have low volumes of urine. So that might be something to talk to your clients about. They also may be dehydrated. So there's a lot of pieces in this puzzle. We've got to act as detectives and really plug in all the pieces and put it together in a way that's informed and educational for our patients. Because some other non-specific symptoms of hypoperfusion could just be weakness, lethargy, fatigue, obviously falls. And something I wanted to make note of right here is you can actually have what's called postprandial low blood pressure, so a drop at orthostatic hypotension. And that's because all your blood rushes to your gut and it takes it away from your extremities, right? So your blood pressure starts to drop because it's all going into your gut. And this can be really dangerous when you have people with autonomic dysfunction, because that may not regulate itself as well as it should. So they could have falls after meals, they could have dizziness after meals, fainting after meals, and that really needs to be something that's addressed with their movement disorder specialist and something that you're aware of. So I'm not sure how many clients will make that connection for themselves, so you need to be aware of that so you can ask them the questions. When do your falls occur? When do you get dizzy? When do you feel the most groggy, fatigued? Blood pressure could be a really big indicator there. So let's get into some techniques that you can use. I conferenced a little bit with the rest of our Neuro collaborative with Julie and Aaron and Claire to see what their strategies were, and we kind of all overlap as far as ways to help people manage their blood pressure. And I'm going to give you some, and I want you, if you use something else, a different strategy, please put it in the comment section below so that we can share with our collaborative here and help build each other up. So if there's something that I missed that I don't mention, put it in the comment section below. Maybe you have a study about blood pressure or autonomic dysfunction that you think would be beneficial for us. Put it in the comment section below. We would love to read it. The more clues that we have about blood pressure in our clients, the better we serve everyone. So here are some different treatment techniques we can use to help our clients regulate their blood pressure. The first one is obviously, using those physical movements to help improve circulation up to your body. So whether it's crossing your legs, raising your legs, crunching your toes, doing your calf raises, abdominal binders is one that Julie mentioned. Abdominal binders can help increase that abdominal pressure, intra-abdominal pressure, and help regulate the blood pressure that way. And different ways to contract your lower body so that you're really using your muscle pump and getting it back up to your heart, your brain, all the important tissues that need it. The second way is very similar, but it's just obviously something we're big proponents of and something that needs to be researched more. But as we exercise, and we exercise with our clients more, we're increasing the tone of the lower body muscles, and just having that increased tone and having them be more active is regularly circulating blood up to your tissues and your extremities. And it's really important if you have someone with a neurological degenerative disease to be monitoring their blood pressure while they're exercising so you know where they're at and you can keep them safe. Some other things to avoid is educating your patients on not hopping right out of bed in the morning, going from laying down to scurrying into the bathroom. Their blood pressure is going to be lower because they're dehydrated potentially. Their blood pressure medications may be in or out of their system depending on what they're taking. So educating them on not going from laying down sleeping to running for the bathroom right away if they can help it, sitting up, letting that settle, getting their legs moving. Obviously you want to avoid jumping right out of bed if you can. Helping them understand what it means to have low blood volume as far as hydration is concerned. So this is something that I plug with every single one of my clients. I'm sure you guys do too. But if you're dehydrated, then your body can't function the way that it needs to. So actually you can do, in the hospital they call it a bolus, but drinking about 400 to 500 milliliters of water, hopefully with some electrolytes in it, can help immediately raise your blood pressure within minutes and keep it elevated for 20 to 40, potentially 60 minutes. And that's a pharmaceutical approach that helps you bring your blood volume up, helps you reperfuse your organs, and helps you feel better. So we need to be encouraging our clients to drink water, use electrolytes if you can. Something I really think is beneficial is adding Celtic sea salt, about 1/4 of a teaspoon of Celtic sea salt to a liter of water. Celtic sea salt is different than table salt. It's got a lot of minerals, a lot of electrolytes in it. It's not enough to, be dangerous for people on low sodium diets. It's 1/4 of a teaspoon, and you put it in a liter of water, shake it up, drink that, and it actually helps you absorb your water a little bit better. But that could be something that you recommend to your clients. I know there are electrolyte tablets, trying to avoid things like sugar-heavy Gatorade. I won't go on my nutrition rant at the moment, and I'm sure Claire will try and stay off of hers as well, but using electrolytes can be really beneficial. And then also compression stockings. So there's over-the-counter compression stockings that are lower pressure than the prescription grade, but they may need to go for a consultation for compression stockings, assuming that they don't have any comorbidities that limit their ability to wear compression stockings. They don't have heart failure, or if they do, working with their healthcare team to make sure that they have a good balance of, safety but blood pressure regulation. So one thing I did want to, let me just say, if you guys have any questions, I don't see them on my phone, but I'm going to go to the Neuro Collaborative page here and see if I can find it. One question that was asked at the Vancouver conference was about this balance between clients who have super high blood pressure or super low blood pressure. What are some strategies that we can use to help people when they fluctuate a good deal, which could be a lot of our patients at any point in time. There's lots of comments. Okay, I'll read those here in a second. But the answer to that question, and the lecturer was Chris Mathias, and I can post his name and some of his studies on the comment section when I'm finished here. But as far as, sustained or not sustained hypertension, so just intermittent elevations in blood pressure, which potentially happen the most at night when you're laying down and you have really high blood pressure, that kind of intermittent, really high blood pressure versus sustained severe hypotension. Which one is more dangerous? And what he recommended was that severe low blood pressure over time, that chronicness, actually is more dangerous because you have a chronic hypoperfusion of your organs. So you're damaging your organs over time significantly versus occasional blips and really high blood pressure. So what he recommended was at night, if you're having high blood pressure at night, you can use an incline wedge about 60 degrees, or recommend to your patients to do that, about 60-degree incline, to help them avoid getting a lot of hypertension, in their brain, and increasing their risk of a stroke or another stroke for some clients. Avoid using medication at night to lower the blood pressure, because people will pass out when they get up at night. And then in the evening, he actually recommended a few things that are non-pharmaceutical. He said alcohol, if they have that high blood pressure at night, alcohol can help keep blood pressure a little bit lower. This was from a physician recommending alcohol. Having some type of carbohydrate before bed, and then of course staying hydrated, can help them regulate their maybe blips in high blood pressure that they get every once in a while, instead of always erring on the side of really, really low blood pressure. That's just a little bit more dangerous, a lot of it more dangerous for our clients. And so just being aware of maybe the strategies or the goals of managing blood pressure from a physician's standpoint is helpful for us too, so we know how to educate our clients and we're all on the same page. So that is, let me just go over here and make sure that I don't have any questions. I don't see any questions, but if you guys have any strategies that you use to help your clients regulate blood pressure, I'd love to hear them. Put them in the comment section below. And of course, again, join our free Facebook group. We'd love to collaborate with you, answer your questions, talk about case studies, watch videos. We're in there for you guys. So if you guys don't have any questions, I'm going to go ahead and sign off here. We will be back in a few weeks with another Facebook Live, and just appreciate you guys tuning in. So if you found this helpful, share it with friends, share it with colleagues. We would really appreciate it. And make sure you subscribe to our YouTube channel as well. All right, see you later.